thank you for coming in this afternoon to our presidential address. We're really happy to have you all here, and I'm even more delighted to welcome our presidential speaker, Dr. William Croyle, who I will tell you a few words about, and then I will turn... Robert Croyle, and I will tell you a few words about him, and then I will turn the podium over to him to tell us some things. So Dr. Robert Croyle, he's the director of the Division of Cancer Control and Population Sciences at the National Cancer Institute. He's been there since 2003, so you can imagine he's developed quite an extensive portfolio and expertise in this area. The division itself covers a wide range of topics that are really relevant to prevention science, including epidemiology, behavioral science, surveillance, health sciences, research. So a lot of topics that are really near and dear to the heart of prevention scientists. Now, before coming to National Cancer Institute, he was a professor of psychology and a member of the Huntsman Cancer Center at the University of Utah. Prior to that, among other things, he was a visiting investigator at the Fred Hutchinson Cancer Research Center in Seattle. And, continuing his, you can see where he came now. He originally got his PhD in social psychology from Princeton back in the mid-'80s. So that's a little about him and the Institute itself. He has done himself some groundbreaking research in areas of how people process, evaluate, and respond to, cancer risk. If you Google him, you'll see he's had some really highly cited publications in this area, often garnering over 500 or 1,000 citations. He's been honored with numerous different prestigious awards, including being a member of the Academy of Behavioral Medicine Research, a fellow of the American Psychological Association. He's had lots of awards, including from NIH, including the NIH Director's Award twice, in 2000 and again in 2015. So without further ado, I'd love to welcome Dr. Robert Croyle and turn the podium over to you. Thank you.
Thanks, Leslie, and thanks SPR for the invitation to come to your meeting. I'm glad to be here, and I think SPR has a unique niche among all the conferences, and it's great that it's ongoing and well attended, because I think as over the years, so many of us who work in specialty areas have spun off into specialty conferences on single risk factors or single populations or particular diseases. I think it's really important to still have a venue where folks who work across different risk factor domains come together and talk about mechanisms and processes and models of etiology and prevention. So thanks for all the work that you do. So I know for all of you, it's been a long day of jillions of PowerPoints and lots of structural equation models and things of that sort. So I'm going to try not to show you too many data slides, but maybe talk a little bit more informally about where things stand in terms of cancer and cancer prevention. And I'll focus a little bit more on some of the kind of the subtopics that are less usually covered at SPR, because so many of the chronic disease risk factors we have in common, whether it's cardiovascular disease, cancer, diabetes, et cetera. So a lot of you work in areas that are cancer relevant, whether you identify as a cancer researcher or not. And so I'm going to talk a little bit about kind of bigger picture issues in cancer. And part of that happens today because once a year we have a big rollout event, and today is our day, a report called the Annual Report to the Nation on Cancer. And so that's something that we're responsible for doing. And that was released today. And we do that in collaboration with CDC and American Cancer Society. And it usually gets lots of press coverage, in networks and all kinds of media, so you'll probably be seeing various stories about that. So I'll make a couple of references to that, because each year when we put out the annual cancer statistics, incidence, mortality trends, et cetera, we also talk about and feature some particular aspects of cancer that are changing, increasing or decreasing. So I'll talk a little bit about that. Also, I want to say a couple of words about NCI, because NCI is a little weird at NIH. So we're the largest institute, but we're a little bit odd in the sense that due to the National Cancer Act of 1971, We're the only institute among the 27 at NIH that has a presidentially appointed director. And depending on who you ask, that's a good thing or a bad thing. As somebody who's like a direct report to the NCI director, one of the consequences of that is every 4 years, I have a new boss. So there's a lot of kind of leadership change and flux at the Institute, but it also affords us kind of a special opportunity or entree in a lot of discussions, policy discussions or executive level discussions that otherwise we wouldn't be invited to. So the other thing is I will mention a couple of the areas that have been kind of priority areas for us at NCI in terms of prevention and behavioral science, especially these last few years, that I won't be spending much time about today, but I want to give them a little bit of a shout out, just to say that they are priority areas for us. So one is in the last few years, and we've been working with several other ICs on this, institutes at NIH, is implementation science. And my deputy director for implementation science is David Chambers, who some of you know used to work at NIMH and has been a real leader of this field at the NIH. And so he asked me to put in a plug for this year's Dissemination and Implementation Science Conference, which we're pleased to be involved with and co-sponsor. Academy Health now is kind of the organizational host of that, which makes it a little bit easier not being a government meeting anymore because of all the rules and regulations about that. But dissemination and implementation science, I wanted to mention, also has been kind of elevated at the NCI last couple of years because of the cancer moonshot. And the cancer moonshot was a special authorizing bill passed by Congress a couple of years ago, named after Joe Biden's son. It's the Beau Biden Cancer Moonshot Initiative. So it's both an authorizing bill and a special appropriation. So this year, for example, in NCI's appropriation, we have an additional $400 million just for the NCI Cancer Moonshot. And working with the advisors who put that together with the then Vice President Biden, one of the priority areas of the Cancer Moonshot is implementation science. And so some of you have seen, we've put out a whole series of RFAs the last couple of years related to this. This year, we're excited that we're going to be funding the first implementation science research centers. And that's going to be one of the kind of the signature components of this initiative. Another area that we continue to be really active in, and again, I won't be spending that much time on today, is really kind of the applications of technology, which has been a real theme of this meeting in terms of mHealth, et cetera, interventions. So I won't be spending much time about what NCI is doing in that area, but all of you have heard about a lot of work funded by many of the institutes at NIH in that area. Also, one of the things that I think for those of you who are at academic institutions that may or may not have an NCI designated cancer center, I wanted to mention that because for somebody coming from a behavioral science or prevention background, one of the things I wanted to mention was what are the virtues of kind of having a little bit of involvement or collaborating with or getting to know colleagues who work in the various cancer prevention and control domains. And one of the resources that affords you, and some of you in the room who work in these areas that are NCI funded or co-funded are really aware of this, is that among the different areas of biomedical research science in the US, the largest scale research infrastructure in the United States is the cancer research infrastructure. So by collaborating with the folks who are working in the cancer domain, it opens up a lot of opportunities related to the big data theme of this year's meeting. So lots of sources of data for secondary data analysis. We link all the cancer incidence data across the entire nation. We collect detailed data on every cancer case in the entire United States, and we link those data to dozens of different other data sets. Things like the Medicare Health Outcomes Survey, survey data, Medicare claims data, on and on and on. And so if you have a research question that you're pursuing relevant to prevention, and one thing is always to check with a colleague or with somebody at the Institute at NCI about whether or not there is a data source or resource related to that. One of the ways that a lot of this work gets supported is through the NCI designated cancer centers. That's a big component of our research infrastructure. NCI now funds 70 cancer centers in the U.S., and we're probably going to be adding another one this year. And a lot of special funding to people in prevention and behavioral science occurs through those cancer centers and their affiliated programs. This last year, we've added a substantial additional requirement that every NCI cancer center has to fulfill, and that is having a substantial community outreach and engagement, research, and application program. So if you have interest in kind of community engagement activities, happy to talk to you further about that. So because it's the end of the day, I thought I'd focus on bigger questions that oftentimes I get asked, like you guys do about your work when you're sitting on a plane and somebody says, oh, where do you work, whatever, and then you say National Cancer Institute, and if that's your answer, I've learned not to say I'm a psychologist. I don't go you know about that. Don't go there. So if I say National Cancer Institute, then immediately you hear about people's individual experiences and family members, personal experience, et cetera. But the question that you always get asked is, so when are we, or how close are we to a cure for cancer? And then so you have to start with there are about 200 or so different types of cancer, and so for some cancers there are cures. Which oftentimes people aren't aware of. And for some types of cancer, we're not even much closer than we were 20 years ago. So the heterogeneity of cancer adds to the complexity when we talk about prevention, and particularly the behavioral science of prevention in cancer, because the etiological pathways for ER-positive breast cancer versus colorectal cancer versus melanoma versus prostate cancer versus head and neck cancer, all of these have different etiological determinants and pathways. So how behavioral science fits into each of those varies across each of these cancers. So it makes it an especially daunting challenge in terms of prevention science and cancer, particularly for all the kind of the work that those of us in the room do, because these different pathways are so different and complex. And almost every day we're discovering another new molecular subtype of cancer. So we used to talk about breast cancer, now we talk about 5 different major categories of breast cancer, but again, next year there'll be additional ones as we genetically sequence tumors and determine that, gee, what we thought was one cancer actually is 2 types of cancer. So this adds to the complexity when we think about how we're doing in the war on cancer. So this is the real basics. One of the oftentimes unappreciated stories about cancer, similar to cardiovascular disease, is that the progress over the last several years is quite good. So the national mortality rate in cancer in the U.S. has been steadily declining since about the early 1990s. So on the left there, you see long-term cancer mortality rates in the U.S. Steadily going down, but the top line there is males, so cancer mortality rates are higher in males than females. Smoking has a lot to do with that. And then on the right side, I've split out black and white differences. Like a lot of diseases, the biggest health disparity, largest in terms of effect size health disparity in cancer in the U.S. is the African American versus white difference. But I'll break that down a little bit more with other subgroups. But one of the good news aspects of this story is, as you can see on that figure on your right, the size of the disparity, the gap is closing. So we are steadily closing the black-white gap in cancer mortality. And this has been our most severe population level burden disparity. So, as many of you work in many different areas, but as you all know, tobacco use is still the leading cause of preventable death in the U.S. But there's been remarkable progress, and I'm going to be bouncing back and forth between good news, bad news, progress versus challenges throughout my talk. So first we got to step back and recognize, as always, how much has been accomplished in terms of tobacco control. And so there's many different figures you've seen. This is one that's used a lot about different events, and basically since the Surgeon General's report of '64, we've had steadily declining rates. And recently you've seen, and whether you look at Monitoring the Future or NHIS or CPS, Current Population Survey, they all show the same thing, and that is we're still going down in terms of population rates, prevalence rates of smoking, and we're now at the lowest rates seen since these data were collected prior to 1965. So that's a great news story, and that has had a huge impact on cancer incidence and mortality rates. Tobacco use accounts for about a third of all cancers, so there is no such thing as cancer control without effective tobacco control. And for some constituencies, policy constituencies, scientific constituencies, even some basic scientists for many years, just simply getting the message through of the scale and importance of tobacco use for cancer, as well as many other diseases, is something that we can't forget, and we have to remind people of, because for many people in the policy area, oh, this is like an old issue. Wasn't that 2 decades ago, whatever? And if you live in some place like California or San Francisco that has really strong policy, you don't see a lot of smoking. But stop by a cafe for breakfast in Alabama, and it's a whole different story. So this is one slide I used just to kind of frame things, because the visibility and the salience of the opiate drug epidemic is so huge in the country today. And so if you take the total death toll in the U.S. from drug overdose, not just opiate drugs, whatever, it comes out to about 70,000. And again, put this in context, we're still at 480,000 deaths per year due to tobacco use. But you seldom hear it discussed as a crisis. So this is a slide I often use in terms of showing subpopulation breakdowns of various sorts. And there's one that's a little bit hard to notice here. Let me get my pointer. That I wanted to point out to you, because in cancer, it's one that we have a special emphasis on. And I know Kathy Etz is here from NIDA, and she was recognized by SPR last year for her work on American Indian Alaska Natives. And this has been a special current focus of this the last couple of years, because it's quite an outlier and oddity. It's a little bit hard to see, but it's a remarkable statistic. And that is, if you look on the left side here, there's one line here in terms of cancer incidence trends over decades, which has not budged at all. And that's American Indians. That is, despite all the science, all the advances, all the discoveries, the hoopla, the press, new drugs, new modalities, new screening modalities, we've got one population that the incidence rate has not budged at all, and that's American Indians. And that's one reason why we're putting a special effort on that particular population. Shobha Srinivasan at NCI coordinates that effort. But mostly what the public sees and has seen, and appropriately has been visible, is that the last few years something new and different has happened in the world of cancer and cancer treatment. And if you had a relative who's been diagnosed with cancer in the last couple of years, and you compare their experience to one who might have been diagnosed with cancer 15, 20 years ago, it's completely new. It is night and day. And that is because, right now, another meeting that's about to start in Chicago is the annual American Society of Clinical Oncology meeting. And if you went to the American Society of Clinical Oncology meeting 15, 20 years ago, it was not unusual to go to that huge national conference and there not be one new, efficacious, FDA-approved treatment for cancer discussed. It was just trial after trial after trial with negative results or disappointing results. And it is an entirely different story now. So with not only immunotherapy, which a lot of people heard about and molecularly targeted therapy, just in the last year, this is a list of new cancer drugs that were approved by the FDA just in 2018. So there's been an incredible explosion of advances in cancer treatment. And a lot of this has been driven by advances in basic science, genomics, and understanding the biological mechanisms underlying cancer. So that's a absolutely good news story. And it's had impact, and it's detectable statistical impact already in a lot of different ways. There's a lot of different ways you can look at this. One way is looking at survival rates over time and survival statistics. That is, how many people, what percentage of people survive at least 5 years post-diagnosis. That has been going up steadily. But you can see some notable exceptions. Look at pancreatic cancer, third from the bottom there. So Alex Trebek, has been talking about this with his diagnosis, whatever, and he's shown some good initial response to his initial course of treatment. So it's not good news across the board. But, on that far right-hand column, the survival rates have been going up, and for some of them are remarkably high. But so what is this? How does this relate to prevention? Well, with every scientific and public health area of progress comes new challenges. So you make progress in one area, for example, greatly improved cancer therapies, and I'll come back and talk to about this at a couple of points in my talk. But what that means also is that there are millions more people living with cancer, or people who have been at some time in their life diagnosed with cancer. And those people have needs and issues and research questions related to prevention, about preventing a recurrence of their cancer, or preventing a second cancer, or preventing comorbidities. So the issue of cancer survivors and cancer survivorship is now bigger than ever because of the improvements that have come in drug treatment. The other one is the fact that if you're at a university with an academic medical center, if you have a medical school at your university, and you pull aside the chief financial officer of your academic medical center, and you give them a couple of drinks at a cocktail party, they will admit to you that from a financial perspective, cancer, oddly, is a winner for the financial manager of your hospital or your medical center. Why? Because now oncology and oncology care and oncology services are the biggest revenue generator of a medical center or medical institution or academic hospital. And one of the reasons is that all those new drugs I showed you on that slide are astoundingly expensive. And so this was highlighted by Barbara Reimer, who until recently was chair of the President's Cancer Panel. So she was appointed by President Obama, and then her term ended, and the current president has not appointed a new President's Cancer Panel. But their report that came out last year kind of really focused on this, and there was a National Academy report. And so you've heard a lot of talk about drug prices and the issue about drug costs, whatever. Cancer drugs are really, in an awful way, leading the way in terms of costs. They mentioned here that most of these drugs cost more than $100,000 for a one-year course of treatment, but that doesn't mean that there aren't many that are many higher. Some $400,000 for one-year course of treatment. So this raises all kinds of issues, because the economics of the cancer treatment then impacts behavior of patients. How people behave. Do they go to the pharmacy to fill their prescription? Are they able to pay the copay? Do they comply and adhere with the treatment regimen? And so this term that we now use a lot, we talk about the toxicity of cancer treatments. Your hair falls out, you lose weight, there's nausea. Financial toxicity now is as important as these other biological toxicities. And therefore, the health economics and the issues surrounding health economics of cancer are front and center, and therefore we feel strongly about the importance of supporting research in health economics, economic aspects of cancer, and how that impacts on patients. And you've seen this before, but again, putting in the context, just because you spend a ton of money doesn't mean necessarily you get the return. And so U.S. is the outlier, of course, in terms of spending, but not getting the bang for the buck and when you compare us against other nations who spend a lot less and have better overall outcomes. The other issue is that I showed you that graph before about the great success in reducing the number of smokers. Again, that's the good news, that's fantastic, but there's kind of a challenge that comes with that progress, and that is we have a growing number of tens and thousands of people all across the country who, we've got them to quit smoking, but the day you quit smoking, your cancer risk does not go to zero. So your cardiovascular risk, as many of you know, drops fairly rapidly, like your risk of a heart attack. And some of you here have been involved in studies showing that, after you pass a clean indoor air law, you see immediate impact on lower emergency room visits for heart attacks, for example. But for cancer, the risk goes down more slowly. And so now we have all these people who've done what we want them to do. They quit smoking, but they're still at high risk for cancer. So what do we have to offer them? And so one of the largest prevention-related trials that NCI supported at the tune of about $200 million, so it wasn't a cheap study, was the National Lung Cancer Screening Trial, which some of you have probably heard about. And the NLST, the National Lung Cancer Screening Trial, was a large randomized trial to test the notion of taking people who are high risk of cancer because of their smoking history, and maybe they've quit recently or some of them still smoking, and then randomize them to either a CT scan of the chest versus traditional chest X-ray. And so this was a huge, ambitious effort. I won't go through all the characteristics of the study, whatever, but basically showed that about a reduction of a little less than 20% of lung cancer mortality reduction of those in the intervention group who got these CT scans of their chest as opposed to X-ray, which is pretty useless. So early detection through screening and the gap in terms of mortality started to appear around year 6 or 7. That's what this shows. So it takes a little time to show the significant effect, but that keeps widening over time. You see it more clearly when you look at people who are diagnosed with lung cancer and where early detection makes a difference by screening, because if you look at this case survival statistic comparison of the intervention group versus the lower group, the red group, which is the X-ray group, the old-fashioned X-ray, which is pretty useless, you find a substantial effect. So again, here's another case of a major advance in cancer research that's prevention-related, but then still poses a whole new set of challenges. So in reviewing the evidence of that trial, both the Preventive Services Task Force and other organizations now recommend this for people at high risk who've had these 30-plus pack years of smoking history. And so a lot of people who were involved in the trial like, hey, great, we're done. We did the trial, we got a good result, and now we're ready to move on to the next thing. The difficulty is that a lot of people who've stood up and who are running these lung cancer screening programs, and many of them have been started at universities all across the country and other centers, have noticed a curious thing, and that is a lot of people coming in for screening are still smoking, okay? And the idea is, well, I'm still smoking, and my doctor recommended me to get a CT screen of my chest to see if I have lung cancer. And what would be a great result? Well, I don't have lung cancer. Keep on smoking. So the challenge is that although all these guideline organizations say in their recommendations, whether it's CMS or Preventive Services Task Force, whatever, that if you're screening somebody for lung cancer, you should also provide cessation services, clinical cessation services to all smokers. How many radiologists know how to do that? Zeroid. So here's a whole other secondary prevention challenge. You're identifying all these people at high risk. Some of them go through, regardless of the lung cancer screening result, here's the huge teachable moment and the opportunity. Because if you model it out statistically, what you find is that the biggest impact of lung cancer screening on reducing disease risk is not the screening, and it's not the communication of the test result. It's the opportunity you have to get smokers to quit smoking. That has a bigger impact, if you can get them to quit smoking, on risk reduction of cancer than does the lung cancer screening. But we saw right off the bat that wasn't happening very effectively. So we funded an RFA that Stephanie Land leads at NCI and funded 8 projects to develop and test how do you implement, again, an implementation science challenge, how do you implement evidence-based smoking cessation within the context of a radiology clinic doing lung cancer screening? Not easy. So we've got plenty of evidence-based cessation modalities that have been reviewed and hundreds of studies, et cetera, but a complete disconnect between the existence of that evidence and then the delivery of that evidence in a context of a high-risk group. So all of these folks that we're funding are testing different strategies to incorporate cessation into radiology clinics doing lung cancer screening, and those results will be available in a couple of years. The other thing that we've done with collaboration with other institutes at NIH, of course, is to scale up all the other services we provide. So one of the things that NCI does for the department as a whole is we run and host a website and many ancillary websites called SmokeFree.gov. So if the only thing you remember today is this, SmokeFree.gov, write that down, because every patient that you see and encounter who smokes should know about this online source of support. It's the nation's, in a sense, website and web-based support for quitting smoking. And there's text messaging and all the other bells and whistles that you expect. And across the top there, you can see we have a SmokeFree.gov main one, but we also have tailored and designed versions of SmokeFree.gov for veterans, for women, for Spanish speakers, and for multiple different audiences. And this also links to the National Quit Line network. Okay, and again, a lot of people don't realize that if you call a smoking cessation quit line, some states run their own, but many of them actually send your call to Seattle, where a person who runs the NCI Cancer Information Service at Fred Hutchinson Cancer Research Center picks up the phone and helps you to quit smoking. So another challenge and opportunity, and what was mentioned just a little bit at this conference, because I know there was one session Jasmine Tiro and others were involved with that I saw on the program on HPV infection and vaccination, is a lot of the public, and I would guess maybe some of you are maybe not widely aware of the role of infection in cancers and cancer etiology. And so I thought I'd say a little bit about that, because here's another tremendous prevention opportunity, which depends on behavior change and behavioral science, where we need your help and engagement. So stepping back at kind of a more of a global level, so this is just by way of background, if you're not familiar with this, infectious agents cause almost 20% of all cancers globally. And that's something that is oftentimes just not on the radar screen of health policymakers or elected officials. If you work at the World Health Organization, you're aware, whatever, and there's an effort now, and the WHO, Tedros, the new director of WHO, one of his top priorities is cervical cancer control. But this is an area where trying to just increase the level of familiarity and awareness among the health sector and health experts has been a real challenge, because I'm also serving currently as our interim director of global health at NCI. So I've been kind of encountering a lot of discussions on this with officials from other countries and from international organizations. So infectious agents are important for a variety of cancers. Stomach cancers, most stomach cancers are caused by a bacterium, H. pylori, so that's domestically, internationally. HPV, which many of you have heard of in terms of cervical cancer, but I'm going to be talking about its etiological role in other cancers. One of the cancers that is going up in terms of rates, incidence of mortality in the U.S. is liver cancer, which is associated with hepatitis B infection and other risk factors, hepatitis C as well. And then I'll show you a little bit of how this breaks out in terms of globally. So this is just focusing in now on cervical cancer. And again, a lot of people don't realize cervical cancer is a totally preventable disease. No woman should get cervical cancer. No woman should die of cervical cancer. And the fact that any woman in the U.S. dies of cervical cancer in the U.S., especially a higher income country, is an embarrassment. So you can see that cervical cancer burden is quite high in poor countries, in Africa, South Asia. And the great progress in cervical cancer in the U.S. has been through early detection and prevention, the Pap smear, right? And the use of implementation of the Pap smear, because we have a large healthcare infrastructure, not an organized one, has had a huge impact on reducing the cases of invasive cervical cancer in the U.S. But we can do a lot better. That should be zero. Now, if you take, I've tried this on riding on airplanes and stuff. If you ask the person on the street, if you were to find out tomorrow through some crazy miracle that some scientist invented a vaccine that could prevent cancer, would you want that vaccine? And everybody goes, yeah, of course, okay? But it's not happening, and I'll talk about some of the reasons. We tried to have a meeting with a number of organizations a couple of years ago in Mississippi, and the head of the Family Practice Association in the state, and when we brought up the issue of HPV vaccination, for cancer control, it said, well, that's not something I can support because it facilitates immorality in our girls, okay? So this kind of crazy notion that if you give a 12-year-old an HPV vaccine shot, she's going to immediately go out and just have sex with every Tom, Dick, or Harry, unfortunately is prevalent and something we're still struggling against. There's the general anti-vaxxer stuff going on that kind of adds to it, but in HPV, the mistake that we made as health professionals early on was, in a sense, kind of framing it as this is a vaccine that controls a sexually transmitted infection, as opposed to here's a vaccine that prevents cancer. Two very different ways to frame the same vaccine, the same intervention. HPV, as it turns out, is important not just only for cervical cancer, and this is not widely appreciated in the U.S. or even globally. So this shows you cancers attributable to HPV infection. As you can see at the top there, 100% of cases of cervical cancer are due to HPV infection. But so are a substantial number, 70% of vulval, vaginal cancers. Penile cancer is rare, so the length of those bars indicates the number of cases in the U.S., kind of the population burden. But 63%, the majority of penile cancers, we believe, are HPV etiology. Anal cancer, which is something you only hear about if there's a celebrity diagnosed. I think the last time, Farrah Fawcett was maybe the last time a lot of people even heard about anal cancers. But again, HPV infection etiology. And then more recently, and really not appreciated, oropharyngeal cancer, both in men and women. Probably the last celebrity who talked about this explicitly was Michael Douglas when he was diagnosed with an HPV-associated oropharyngeal cancer. And the trends over time, I don't have a slide with this, is that as we make more and more progress in terms of cervical cancer, which we are, what we're going to find is that the most common HPV-associated cancer in the U.S. is going to be oropharyngeal. The cancer is also a lot more geographically disparately distributed than people appreciate. So this is the case for a lot of illnesses, diseases, risk factors that everybody in this room studies. So we appreciate that for opiate drug abuse, for suicide, for depression, et cetera. But I think when I interact with staffers on Capitol Hill or members on Capitol Hill, a lot of them don't really realize how much geography has to do with cancer. And so we've been spending a lot of time the last few years interacting and engaging with the geography community in academia, American Association of Geographers and organizations like that, and really supporting a lot more geospatial work on cancer to understand this better. A couple of years ago, we hosted the first national conference on geospatial methods in cancer research, and we're planning our next one for next fall of next year. But this is really critical from a public health planning perspective to understand kind of these geographic hotspots of cancer. And it's certainly the case when you look at HPV-associated cancers. And not surprisingly, you find, a lot of this matches up pretty well. On the left, it looks at HPV vaccination rates, and you see those states, Arkansas, Mississippi, Kentucky, Tennessee, that I know some of you here are from. And then you look at the Southeast, the incidence of HPV-associated cancers being much higher. So there's a regional variation. A lot of that has to do with what's the rate of HPV vaccine uptake. The other issue that this calls into question, HPV vaccination, and there were, again, I mentioned a couple of sessions in this meeting on this topic, is that this is a domain where how prevention science interfaces with communication, health communication, and science communication is really key. I already talked about the framing of the vaccine, that is, the mistake we made by saying, this is a sexually transmitted disease, and then that led people to say, I don't want to vaccinate my daughter for that because, she's going to be abstinent. She doesn't need a vaccine. And then the second issue, the fact that increasing awareness that males carry HPV infection, males transmit HPV infection, males get HPV-associated cancer, so it's not just a female issue, it's a male and female issue. So one of the things that we've really invested a lot in the last few years is communication science, kind of the fundamentals of health communication, both at a mass media, interpersonal, and social media context. And this really dates back to 1998. We had a risk communication conference that had a whole series of recommendations, many of which we're still implementing. But there was a recommendation to NCI that really significantly scale up efforts in communication research. And we have done that. So for 10 years, we funded P50 Centers of Excellence in Cancer Communication Research. And then there's been a number of initiatives since then. I'll just mention a couple of those. One of the recommendations of that meeting several years ago was that NCI should expand its surveillance activities to monitor the U.S. public's knowledge and beliefs about cancer. And so we've been doing this since 2004. And I really recommend this to you or your graduate students, the Health Information National Trends Survey, or HINTS. It's one of the easiest to use, easiest downloadable data sets of any survey. And so it's something that you can really explore. It covers a whole variety of issues, not just cancer related. But the HINTS survey has been kind of our tracking survey of how the U.S. public thinks about cancer, issues like HPV vaccination, issues like lung cancer screening. And we just got very recently the latest data set from the latest round of this survey, and so I wanted to give you a couple of hot off the press highlights of that. One of the things that we've been tracking for a long time is trust. What sources of information do people trust about health? This is one of the many findings in the HINTS survey that is not quite consistent with conventional wisdom. So a lot of people will say, well, nobody trusts the federal government or government health agency. Well, it's still the second most trusted source of health information in the U.S. public. Okay, their own physician, their own provider is still the number one most trusted source. So down at the bottom there, you see, mass media, whatever, that's been discussed a lot, and again, third most trusted sources on the internet, which again, it's a mixed bag, as you know, because the quality of information varies tremendously. We've also been tracking the digital divide, access to the internet going steadily up. We've met Healthy People 2020 goals, but again, there's still a proportion of the population that does not have access. This came up in the last session here in this room in terms of rural populations, and I'll come back to that because we now have a new collaboration with the Federal Communications Commission on broadband access and how that can improve cancer information and treatment and symptom management. But so we're making progress in terms of that. But then when you drill down and look at what people believe about cancer, here's where you find a lot of targets for intervention, communication-based intervention in the prevention domain, and I know a lot of you work in related areas, so I wanted to mention a couple of these just to give you the latest data. So one is when you ask people, do you agree or disagree with the statement that it seems like everything causes cancer? What you find is about 70% of the public says, yeah, I agree. Okay, so it's not that people aren't getting any information. They're bombarded with information and they're confused. It's just like, okay, it's like, is broccoli good or broccoli bad? It's like, eggs are good or eggs are bad, whatever. So it's clear that people have beliefs and attitudes about cancer that relate to their behavior. The issue is the challenge that there's kind of this data smog that they're surrounded by in terms of findings and data, and they're confused by it. And so the issue is people don't have a clear sense of what the most important drivers of cancer are. Still tobacco use, as I mentioned, but there are others as well, as I'll mention. We asked people this question: so many recommendations about preventing cancer, it's hard to know which ones to follow. Okay, how many agree with that? That's even higher. It's about 75% of the public. It's like people are telling me all kinds of stuff, eat more of this, exercise, don't exercise, go on the keto diet, whatever. I mean, there's something new every week. And again, people are massively confused. So there's a fundamental knowledge gaps, and knowledge gaps have kind of fallen out of favor in public health, and right? Behavioral medicine and prevention, because that's health belief model, 1956, it's like, knowledge, okay. It's kind of a boring variable for prevention research, but like another variable I'm going to talk about a little bit later, it's one of the ones that just because we're not focusing on it anymore, it doesn't mean it's not essential and not an important determinant if you measure it in your model. There's not much you can do to lower your chances of getting cancer. Okay, that's absolutely wrong. But again, a lot of the public believes there's just not much you can do. Now, part of this is dissonance reduction because, smokers are more likely to say, it doesn't really matter what you can do, right? So there's a defensive processing cognitive element to this, of course. But again, it's an opportunity in terms of prevention intervention. So here's going back to the geography of cancer. This is what happens, what it looks like if you map at the county level nationally, cancer mortality rates. And I'm going to be talking a little bit about rural health today because one of our real focus areas these last couple of years has been rural populations and rural cancer control, where there's really significant disparities. So I wanted to start out with this because this shows you that although it's clear that many rural areas are where there's greatest cancer mortality, as you can see here, eastern Kentucky, Tennessee, Mississippi, et cetera, rural is not rural everywhere because some of the lowest cancer rates are in rural areas, the Rocky Mountain West. So it's not just rurality that's the driver. There's other factors that interact with and other main effect factors that I'll mention. But the first point here is that geographic variation in cancer mortality is substantial. Okay? And here's the reason why we've focused in our disparities efforts the last couple of years a lot on the rural-urban difference is because, remember I showed you that black-white disparity mortality in cancer, which is still horrible, but it's converging. It's getting better over time. There's one disparity in terms of cancer mortality that's getting worse over time, and that's the difference between cancer mortality rates in rural and urban areas. And this disparity, which is getting worse, again, is not limited just to cancer. So many of you who look at rural-urban differences know that. And so that's been talked a lot about in a lot of different venues in terms of population health and trends. But it's also true in cancer, and especially in cancer. So what is that related to? Well, that's related to the factor that I find in the kind of the government space that nobody ever wants to talk about. If you look at any publication of prevention science or whatever, and so we kind of fall victims to this as scientists, the first couple of variables in the regression, the stepwise regression are, we controlled for age, we controlled for gender, we controlled for socioeconomic status. And then we try to minimize the fact that because I might be interested in a psychosocial variable that accounts for a little small piece of variance, I kind of don't highlight the fact in my discussion section that much more variance is accounted for by socioeconomic status than the attitudinal or cognitive variable that's step 15 of my stepwise regression. And this is the case in cancer, definitely. Cancer, in addition, is always thought of it as a genetic, biological phenomena. But cancer is also a socioeconomic phenomena writ large. And here's the map that looks remarkably like that map I showed you of cancer high mortality rates. And this shows those counties in the U.S. that have shown persistent poverty, high poverty over 3 successive decennial U.S. censuses. And the poverty rate matches up quite closely to the cancer mortality rates. Here's another way to drill into it more deeper. Colorectal cancer is one, like cervical cancer, I look at a lot because it's kind of like a red flag indicator. It's the canary in the coal mine for disparities because, again, colorectal cancer is largely preventable through colorectal cancer screening. If you get a colonoscopy and they see a polyp, they can remove the polyp and then you will not get colon cancer, okay? But what's the issue? Access to health care, access to colonoscopy, access to early screening. It might be fecal blood testing, FOBT, or FIT tests. So we have very effective modes of detecting colon cancer early. And if we detect early signs, we can prevent the invasive disease. This is something we have the capacity to do. But not if people don't have health insurance, not if they don't have health care, not if they don't have transportation to get colorectal cancer screening or a follow-up colonoscopy. So CDC has been very active in this area, as have we, and many state health departments, many state cancer control plans have focused on this because this is one of the biggest missed opportunities to reduce mortality in the U.S. Through colon cancer screening, okay? So you heard about that a lot, but I just, again, want to say this is, again, very, very closely related to access to health care or whatever. You know, you take a state like Louisiana down here, and you dig a little deeper. You know, it's not just about the patients, and I want to really focus on that, because a recent survey of all the gastroenterologists in the state of Louisiana, the people who do colonoscopies, 43% of the gastroenterologists in the state of Louisiana refuse to see Medicaid patients. So what's that about, okay? It's about the money. So colorectal cancer mortality is also an important one to look at in terms of slicing and dicing, because, you know, every time when I go around and talk about our rural cancer control initiative at NCI, a lot of people equate erroneously rural with white. Oh, you're focused on rural because Trump's president, and you're focusing on white people. What the hell are you doing? But some of the most severe poverty are ethnic minority individuals living in rural areas. So it's not just white rural, okay? And this shows you that whether for white or black populations, rurality and poverty of rurality makes a big difference. In both cases, that top line, okay, are those who live in non-metropolitan, persistent poverty counties. So it's an equal opportunity disparity for whites and blacks. So we've been funding, we've funded 21 of our cancer centers nationally to now focus on rural cancer control, and we're going to fund a second round and get most of our cancer centers more fully engaged in this area, because we looked at our own grant portfolio in my division, the Population Science Division, and you know, about 15 to 20% of the U.S. population is rural. 3% of our population science grants that we fund at NCI focus on rural populations. So as many of you know, based on the areas you work in, whether it's opiate drug abuse or alcoholism or whatever, you know, rural has lots of health challenges. One of the things we've found in the cancer community and talking to the cancer centers is a disconnect oftentimes between academic medical centers and rural populations, and that's something we really need to bridge. And closing out, I'm just going to mention a couple other areas of current emphasis. One is social media. I know some of you work in this area. Several of our staff members in my division published an article in JAMA recently, you might have seen, on health-related misinformation. We've had a couple of research workshops on the area of how to study misinformation. A lot of our traditional health communication modalities don't work because people's sources are social media. You know, it's not newspapers, it's not TV, it's Facebook, et cetera. It's where they're getting their misinformation. There is a ton of crap about health in social media, and it's not surprising that people have all kinds of mistaken, erroneous, incorrect beliefs. So we've developed a whole research agenda around this area, so stay tuned to that. I won't go through all the specifics, but check out the JAMA editorial if you're interested. So what are the new challenges moving forward to kind of finish up? What are the things we're worrying about most? Electronic cigarettes, of course, ends. And so we, NIDA, NHLBI, many others at NIH are working on this with FDA. We now have about 35 active grants we're funding just on electronic cigarettes. So this is a big issue, and trying to understand toxicities, et cetera. Marijuana, you know, we have an interagency federal group focusing on how do you measure marijuana exposure. That's a big issue, and a big rate-limiting step in terms of research is just getting good epidemiology in marijuana and good exposure assessment. And then the cancers that are going in the wrong direction. There are a few. Liver cancer, pancreatic cancer is going up. We don't know why. Brain cancer, we don't know why. And obesity and physical activity. So the obesity epidemic is a real problem, not just for diabetes, it's a huge problem for cancer. A lot of the public does not know that obesity and physical inactivity are cancer risk factors. And these are the trends you've seen before, males and females going up and up and up and up in terms of obesity. And physical inactivity and obesity are risk factors for many different types of cancer. So we see this as not just an obesity isolated problem, and it's not just an issue for NHLBI and NADDK, but it's an issue for NCI as well. And so we fund a lot of investigators who work in this area, including behavior change in cancer survivors, physical activity, and reducing obesity. We have a big trial on that ongoing. And then I mentioned cancer survivors. The number of cancer survivors going up and up and up, and we need more effective health behavior preventive interventions for this population. And then I'll mention alcohol and cancer. My good colleague from NIAAA is here. A lot of the public does not know that alcohol intake, high alcohol intake especially, is a risk factor for cancer. The UK has been taking this on very visibly, publicly. We haven't taken this on with the US public. California you do, because you see the warning labels everywhere about that say, the signs that say alcohol is a risk factor for cancer, but that's just limited to one state. And so the scale of the opportunity, what can we do to focus on lifestyle factors? One of the best estimates, I think, is this one from 2016. And they just focused only on 4 behavioral risk factors and found that for people, if you don't smoke, have normal weight, low alcohol use, and you're physically active, those 4 behavioral risk factors alone account for nearly half of all cancers in the United States. Well underappreciated among the members of the public who feel like there's nothing I can do to prevent cancer. And the biggest element in the room I'll focus on is economics. And so here's a recent quote about wealth disparity. In 2018, the net worth of the wealthiest 10% of Americans represented 70% of household wealth, and that's getting worse over time. Currently, the bottom 50% of U.S. households had virtually no net worth. That is the difference between assets and liabilities. That's according to the U.S. Federal Reserve. And a former director way back in 1989 said, "Wake up, people, poverty is a carcinogen." I want to end and give a shout out to our behavioral science team in my division. I mentioned David Chambers already, but Bill Klein is our associate director for behavioral science. And here are the branch chiefs, and I'm also pleased to announce that our health communication branch, we've just recruited a new branch chief from the University of Kentucky, and that will be Robin Vanderpool, who will be joining us in a few weeks. Thank you very much.
Thanks a lot for a great and informative talk. And I'd like to know about the funding trends at NCI and prevention research primarily. We heard a lot from you today about kind of secondary prevention, you know, around ex-smokers, multiple recurrence, because we're worried now that we have all this survivorship. So what are that's a kind of a indicated or secondary prevention. What about primary prevention funds from NCI?
Yeah, thanks. Yeah, because I know David Murray mentioned that he presented some of their analyses, portfolio analysis that Office of Disease Prevention at NIH did of NCI's portfolio showing that trend, whatever. So I'm still trying to figure out that analysis, whatever. So I can mostly only speak for my division. So my budget is $500 million, and it hasn't been declining. But there's many different pieces of NCI that do prevention-related research. One of the I don't know if this is accurate or whatever, because I haven't had a chance to dig into the data deeply with them, but there was an era a few years back where NCI was funding really large-scale, expensive prevention trials, like the National Lung Cancer Screening Trial. We did a prostate cancer prevention trial. We did one on digital mammography. There were about a half a dozen of those, very pricey, and those have all finished. And those big early screening trials, if that was a part of that, could account for that. So in terms of behavioral science, we're still going strong, but it is the case that in terms of kind of more medical strategies and prevention, those are probably less than they have been.
Yeah, and it's you know, clearly all that drug development as well is leading a lot of the treatment side of things, because that's obviously exploded in scope, right?
Yeah, I mean, so something like melanoma, I mean, you know, melanoma was a death sentence just a few years ago, and now no more, whatever. So I think that the question I was throwing out, I guess the theme of my talk, is that whenever there's an advance in a domain, then all of a sudden there's a whole nother new set of questions it poses, whatever. So just as we're dealing with, you know, we've made so much progress on tobacco use, and now, you know, Juul, which is headquartered here in San Francisco, is is rocking along, in terms of, so there's always something new around the corner. And similarly, in the area of disparities, it's not that the black-white disparity is still not huge and immoral, but here's another one that's popping up. So all of us are going to be in business for many years to come.
Thank you very much.